Katie. I'm a student nurse at Art Tech, and I'm just going to be doing a newborn assessment. This is baby Maddie. She's going to be our little patient for the day. I've washed my hands and I have on some hypothetical gloves here. And she's also in a warmer. We would try to keep her covered up for this. I don't have a baby alive sized blanket to cover her with, but we would try and keep her covered up for that. So we will first do a general appearance of baby Maddie. So she is pink. Her skin color is appropriate for her ethnicity. She does have some myela on her face. They look like newborn acne pretty much, and that's normal. That's fine. She also has a stork bite on the back of her neck. Some people call it an angel spot. They're also normal. She has that. She doesn't have any erythema, and she doesn't really have a whole lot of swelling for a baby that was born vaginally, so that's good. Her head is about a fourth the size of her total length of her body, so that's appropriate. And then she has some flexion here in her elbows and in her knees, and then she does have movement in all four of her extremities. And then I like to kind of group her head and neck movement in with this, because otherwise I will forget later, but her head does turn side to side. So all that looks good. And then what we'll do next is we will talk about her respiratory system. So the way that we would assess respiratory rate in babies is we'd put the palmar surface of our hand like gently over top of her chest, and we'd want to listen for a full minute here, because babies naturally have a little bit of an irregular respiratory rate. So we'll time it for a minute, and we'll say it's been a full minute, and then it's normally anywhere between 30 and 60 breaths per minute. We'll say hers was 40 breaths per minute there, and they were normal in depth. We also need to listen to her lungs. So we would use a pediatric stethoscope normally, but I don't have a pediatric stethoscope, so we're going to use the Bell here, but we would want to use the pediatric stethoscope because it's a bit smaller and it's better suited for a smaller patient here. It would give us a little bit more accurate of a reading, but we will listen to 6 spots on the front. And then we would do 2 on each side, but it's kind of hard to do baby Maddie's because she's a baby alive doll. And then we would be mindful of baby's head and neck and kind of just gently rotate her and listen to 8 spots on her back. She doesn't have any adventitious lung sounds there, but we do want to be mindful that babies born via cesarean can still have fluid in their lungs because they're not squeezed the way that a baby born vaginally would be squeezed when they're coming out of the birth canal. So want to be mindful of that in C-section babies, and you'll see me kind of tap that every now and again because I don't want it to stop recording because I've had that happen. So we also need to talk about signs of respiratory distress. So number 1 we'll say is circummoral cyanosis, which is like a bluish color around the baby's mouth. That would be one sign. And then another sign would be nasal flaring. And another sign would be the asymmetrical rise and fall of the chest. So if just one side was coming up. A 4th sign would be retractions. So if baby was having what looks like belly breaths where it kind of sinks in. Tachypnea, I always want to skip that one for some reason, but if baby has a high respiratory rate, that's another sign of respiratory distress. And then grunting. So we want to look out for all those. And then as I'm moving into the cardiac system, I also want to talk about circummoral cyanosis again in regards to congenital heart defects. So if baby has that circummoral cyanosis and it's only happening when they're crying, or it's getting worse when they're crying, then we're worried about heart defects. So moving on to cardiac, the way that we would listen to babies is a little more lateral of the left midclavicular line and at the fourth intercostal space. So we're going to listen to hers for about a full minute. And we'll say it's been a minute. And normal rate for baby's heart rate is about 120 to 160 beats per minute. We'll say hers is 150 beats per minute, and she has a normal rhythm. S1, S2 is heard. With cardiac, we also want to evaluate her brachial pulses and her femoral pulses, and we'll say that they are bilaterally equal and they are normal rhythm and about +2 in strength. So we don't normally assess baby's blood pressure unless they're having complications or if they have a pulse deficit. And if we assess their blood pressure, we would expect the systolic number to be somewhere between 65 and 95 and the diastolic to be somewhere between 30 and 60. So moving on from that, we're going to come up to their head, baby Maddie's head, and we would take a tape measure. I don't actually have one. We would take it and kind of wrap it around, and then baby's head circumference should be about 32 to 36 centimeters, and we'll say hers is 33 centimeters. We also want to kind of look at the suture lines here in between the fontanelles and just make sure that there's no overlap and that the suture lines are well approximated. So baby's anterior fontanelle is going to be a larger diamond shape, and the posterior fontanelle is going to be like a small triangular shape. And then that soft spot in the middle of the fontanelles where that suture line kind of is, we want to make sure that it's not sunken in, because if it's sunken in, it indicates dehydration, and if it is bulging, it can indicate increased intracranial pressure. So babies can also have, I'm probably saying it wrong, but a caput succidium, a cone-shaped head, and that's normal from vaginal delivery. We'll say that baby Maddie does have that because real life baby Maddie had a cone-shaped head. She was a vaginal delivery, so that is normal and it goes away within a few days, that cone shape. So babies can also have a cephalohematoma, so bleeding in between the skull and the cap, and it can be on either one or both sides. Baby, it would take them a few weeks to a few months for that to resolve, but we'll say that baby Maddie does not have that. And then we're going to look at the eyes next. So baby's eyes are normally a grayish color. They don't have a whole lot of coloration to them at first, and then her scleras are white, so that's good. We would also look, so her pupils are round, but we would also look to make sure that they are reactive to light, and they do. Babies don't accommodate, they're not going to fall open light. So we also need to look to make sure that the outer canthus of the eye aligns with the pinna of the ear, the top part of the ear, and hers does. While we're looking at the ears, we're also assessing for periauricular tags, or like almost like little lesions there. And if baby had those, it might indicate renal malformation because the kidneys and the ears develop at the same time. Sorry, I'm looking to make sure I'm still recording because my camera went out the last time I recorded this. But, okay, we did her ears, and then we're going to do her nostril patency. So we would try to close baby's mouth here and occlude one nostril, and then feel for breaths under each nostril. And then we're going to look in baby's mouth for Epstein pearls. They're like little white spots. They're normal, but Maddie doesn't have any. We're also going to assess her rooting reflex. So we would kind of take our finger and place it into baby's mouth. Again, I have on gloves, but baby should gently suck on your finger, and babies think that it's a nipple, so she does have a good root reflex. So another thing is symmetry of the mouth. So we want to make sure that both sides of her mouth are symmetrical and there's no droop there, because if there's droop, it would indicate that she has some facial nerve damage resulting from her vaginal delivery. Another thing that we're looking at is her neck to make sure it's not kind of webbed. And then we're looking for any fat pads on her neck too. And she doesn't have either. So we'll move on to her clavicle to evaluate for signs of trauma from her vaginal delivery. If she had a fracture there in the clavicle, there would be a lump, but she doesn't have lumps in her clavicles. So that's good. And then we'll look at her kind of chest, and we see that it's cylindrical. And then we're going to measure across her nipple line. Her chest circumference should be anywhere between 30 and 33 centimeters, and we'll say that hers is 31. So she also has 2 nipples, and they're symmetrical as well. Babies can sometimes be born with more nipples, but she only has 2. And then I think we talked about everything that we need to talk about there. So we'll move on to her her abdomen here. We're going to look for bulging, and if she has any bulging of the abdomen, it could indicate a periumbilical hernia. And let me go ahead and listen to her. So babies might not have peristalsis for the first few days, or not the first few days, the first few hours after birth. It might take them a little bit for their abdominal sounds to start. But we'll say it's been 6 hours since she was born, so we expect to hear peristalsis. So I'm going to listen to all 4 quadrants here. Okay, she does. And so she has bell sounds in all 4 quadrants. Her abdomen is also soft, round, non-distended, so that's good. We also want to look at her cord. So her umbilical cord should have 2 arteries and 1 vein, and it should be kind of a bluish whitish color. It does get darker and it falls off as time goes on. I think it takes about a week. Next, what we're going to do is assess her reflexes. So Moro reflex or startle reflex is what we'll start with. So we're going to kind of place our fingers here, and baby's going to kind of grab onto our finger. We'll lift her arms up, and we'll kind of gently pull her up just a little bit, and then we're going to let her go. But she's on a soft surface, so it's not going to hurt her. And when we let her go, she should kind of startle, like, you know. And she does. She startles, so that's good. And then we will assess her palmar reflex here. So we put our finger in, she should kind of squeeze with her hand, and then the same should happen with the plantar reflex. We put our fingers here down kind of towards her toes, and her toes should kind of curl around our finger. The Babinski reflex, we would take our finger and kind of make a C shape here. The baby's foot would kind of flare out, and her big toe would kind of flare as well. She would have some dorsiflexion. We're also looking for seminical crease. I don't know if I'm saying that right. But if baby only has 1 crease, that's not normal. Baby Maddie has multiple creases in her hand, so that looks good. And then webbing of the fingers. We're also looking for webbing of the fingers. She doesn't have any. We look for webbing of the fingers and the toes. She doesn't have that, and she doesn't have any extra digits on any of her fingers or toes as well. Let's see. We also need to look for hip dysplasia. So we would kind of take her hips and we kind of rotate them and just kind of feel for any like cracks or like pops that would indicate that she doesn't have good rotation in her ball and joint socket here in her hip. She doesn't have that, so that's good. And I think we've done all of our reflexes, and we talked about her fingers and all that good stuff. So let's flip you over. We can kind of flip her over almost as if we were doing the Heimlich on an infant. So we're going to look at her back here. It's flat and straight. We're looking at her spinal column to see if she has any indentation or like tufts of hair, and that would indicate spina bifida. We're looking for any indentation or dimpling at the sacrum, and that would indicate pilonidal cyst. However, Maddie did have that. Real baby Maddie had like a indentation and dimpling at her sacrum, and it just kind of, make sure I didn't click off. it just kind of went away on its own over the course of a year or two. So I don't know, I think it might be normal in some babies, but that's something I probably should bring up in lecture when we talk about it at our newborn assessment. Just didn't want to wait too long to submit this. But we're also looking at her buttocks to make sure that the folds here are symmetrical, and then we could also, you know, take it a step further and look at the gluteal folds to make sure that they're symmetrical as well, because if they're not, that's another indication of hip dysplasia. So we will flip. Oh, let's do one more thing. Her anus is open, it's not closed, so that's good. And then we'll talk about baby's genitalia. So baby Maddie's a girl. Females can have some labial swelling. They can have vernix, which is like a white kind of coating in between the folds of the labia. They can also have vaginal bleeding or, you know, other types of discharge. Those are all a result of mom's hormones. We'll say that baby Maddie did have some labial swelling. She did. But like I said, that's normal. And then we also want to, I'm sorry, I've recorded this a bunch of times. We also want to gently palpate for the testes to be in the scrotum. So we would feel to make sure that the testes have descended on both sides. We're also looking for, if, you know, baby is a boy, we're looking for a hypospadias or an epispadias. So we're looking to see if the urethral opening is where it's supposed to be and it's not on top and it's not underneath. But of course, baby Maddie's a girl. So I think that covers pretty much everything that was in the rubric. One other thing that I noticed that she talked about in the video was baby's weight and length. So we'll say baby Maddie was 3,200 grams because she was about 6 pounds and 8 ounces. And then I don't remember exactly how long she was. So we would measure from top of her head to the bottom of her foot, and we'll say baby Maddie was about 50 centimeters. Like I said, I don't remember real baby Maddie's measurement there. But that's a normal baby length. So I think that covers everything. But hopefully I didn't miss nothing. Like I said, I've recorded a bunch, so just let me know, and thank y'all for watching.